The following episode is brought to you by the American Urological Association.
Good afternoon. My name is Jay Rahman, and I'm professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series, with this specific podcast being one of several where we are able to talk to the guidelines chair on a newly released or amended guideline. This specific podcast is on the topic of the AUA SUFU guideline on the diagnosis and treatment of idiopathic overactive bladder that was released in 2024. And it is my pleasure to host Dr. Ann Cameron, who was a co-chair of the guidelines panel. Dr. Cameron is the James Monty Legacy Professor of Urology at the University of Michigan School of Medicine. As mentioned, she was chair of the this guideline, and she's also the incoming president of SUFU. And obviously a pleasure to have such a thought leader and expert with us on this. So Anne, always delighted to catch up with you. And again, thanks on behalf of both the AUA and our listeners in taking some time out of your busy day to share some really important updates on this new guideline.
Great. Thank you so much, Jay. And I'd be remiss if I didn't mention Ariana Smith, who was my co-chair on the guideline, who also put substantial effort into this. So I'm speaking for both of us today.
That's super. Maybe even just dovetailing on that, maybe talk, if you don't mind, a little bit, and maybe I'll just broadly ask you on, is this a new guideline? Is this an update of a prior guideline? And then maybe you could talk just in that same light about who are the general components of the members of the guideline and maybe the broad process for it before we dive into some of the details.
Sure. So overactive bladder is a core diagnosis that all urologists see. So this is definitely not the first overactive bladder guideline. There was an original overactive bladder guideline that had a slightly different title. It was overactive bladder non-neurogenic. And that original guideline had a very long literature review that went from 1966 to 2008. That guideline was updated multiple times. And the reason the AUA updates guidelines is because they are an exceptional amount of work from a large number of staff members and volunteers. And sometimes the guideline just needs a touch, an update with the most recent literature. But after a while, the data just gets too unwieldy. There's just too much information. And going back to 1966 seems like a bit much. So starting over, this was a brand new guideline. There was essentially no overlap between the literature review from the new guideline and the old and updated version of the guidelines. Certainly, we reference the old guideline because it was excellent. It simply needed just a brand new overhaul. So this was a new systematic review and went from 2013 to 2023, which is the way the AUA is moving with these guidelines, not diving into the historical literature. There were 159 papers that were included. So this was a very large systematic review. And one major difference in the literature review is that we focused on all genders, not just women, which were part of the updates for the old guideline. So this was a lot of data to review. And in retrospect, we were really glad that this was a do-over, a brand new guideline, because there is such a volume of information, and this space is moving very quickly right now.
So maybe just tied into what you just mentioned, that it was inclusive of all genders. Talk a little bit about maybe briefly just about men and men with obviously maybe with prostate obviously in place, and any guidelines or nuances in the diagnosis and treatment of men. And then maybe we'll more broadly talk about OAB.
Sure. So because of the huge volume of data we did analyze all of the data divided by gender when that was possible. Many of the articles were focus just on women, so that there were a lot of articles that only had women included, but those that had both genders included and the data was divided, we looked at all the information by gender. And not to overlap with the BPH guidelines, which are also an excellent up-to-date guideline, we did come up with some guidelines specific to men. Mm-hmm. So in essence, one of our guideline statements, basically to paraphrase, says, so in a patient who has BPH and also has bothersome overactive bladder symptoms, not slow stream, we're talking about urgency, frequency, possibly urgency incontinence, you can discuss with that patient either initially managing their BPH or initially managing them as if they have OAB with pharmacotherapy or minimally invasive therapies. Again, this is a little bit fuzzy in the data, what is exactly causing this person's symptoms. So we do give people the freedom to engage in shared decision making with that patient, really to determine what's bothering them the most. And again, we do list what therapies are available. So you can treat their BPH and their overactive bladder at the same time, or treat the one that's bothering them the most. Again, this is shared decision making. There's only grade B evidence for this, but this really reflects what clinicians are really doing in their office as well.
No, that's great. I think, and probably just to think about it, I would certainly say that one of the ways that I'd always thought about BPH with overactive bladder is you first treat the BPH and then you address the overactive bladder. But from what you're describing, it's really symptom directed based on discussion with the patient. What are their most problematic symptoms? And you don't necessarily have to follow that maybe sequential path. Is that correct?
Yeah, and I think that's a good way of thinking of it. Again, the patient who presents with mixed symptoms, the guy who has slow stream, nocturia, dribbling, but also has terrible urgency, where do you start? I think that patient, it would be, ideal to treat them with something to help with their outlet, but that may not have a big impact on their bad urgency symptoms. But whereas some guys end up somewhere on the other ends of the spectrum, the guy who has no difficulty emptying, no hesitancy, normal post-forward residual, and just has urgency, maybe that guy would do better with just the OAB therapy. I think we certainly need more literature on OAB in people with prostates. There's a huge dearth of what to do for those patients. And I think there's a lot of opinion out there, but probably not a lot of hard science. And our guideline addresses how, we're in desperate need of information in that patient population.
So what, as you review the literature for the guideline and you formulated the guideline with the team, maybe talk to us about, what's new in the diagnosis. And then I think not more importantly, but equally importantly, talk about the initial assessment and what should people be doing when they're confronted with patients in the office, what sort of symptom complex. Talk to us about both of those.
Sure. So the diagnosis of overactive bladder, in essence, really hasn't changed. It is urinary urgency. That's a core symptom. If you don't have urinary urgency, you probably don't have overactive bladder. But it's usually urgency with frequency nocturia. They may or may not have urgency incontinence. And this is in the absence of other obvious pathology. Things like urinary tract infection. If someone has a urinary tract infection today, you can't diagnose them with OAB without treating that infection. Someone who's had prostate cancer radiation or other radiation of their GU tract, or someone who has a stone in their bladder, you can't diagnose those people with OAB. Again, and this is inclusive of neurological conditions, things like multiple sclerosis, Parkinson's disease, or spinal cord injury. Those exclude people from a diagnosis of overactive bladder. Not to say that this guideline doesn't help you manage those people. I think the recommendations that we're giving, the treatments that we're giving, treat urgency and urgency incontinence, but you don't label it as idiopathic overactive bladder when there's an identifiable cause. So this guideline will help you with those people, but this guideline really refers to your idiopathic overactive bladder, meaning there's no pinpointed diagnosis. And one other diagnosis of exclusion is polydipsia. So those patients who are consuming liters and liters and liters of fluid every day and are complaining of urgency, they really don't have overactive bladder. They have a fluid consumption problem. And patients with nocturia all by itself, that's not overactive bladder either. You have to have urgency to have overactive bladder. So that really hasn't changed. We reemphasized it in the guideline because this is core clinical skills. But, to move with the times, we did include telehealth as an option, both in the diagnosis and the follow-up of this condition. So it is totally appropriate for you to initially see a person with symptoms of overactive bladder via telehealth. You can assess their symptoms. You can do a past medical history. You can cover their surgical history and their symptoms in detail. Clearly, you can't do a physical exam via telehealth, but you can defer that to their next visit. And you could certainly engage in treatment decisions based on the person's presentation. And we all have access to a lot of electronic medical records. So accessing their urine results from their primary care physician, if you've ruled out hematuria, if they've had imaging that shows that they have a normal post-void residual, you already have a lot of information on that person. And again, you can order a urinalysis and do a pelvic exam at a later date, but there's no reason you can't engage and begin the conversation, begin the treatment plan with this person based on clinical common sense. Again, there's no need for diagnostic intervention to diagnose overactive bladder. You don't need urodynamics. You don't need a cystoscopy to diagnose overactive bladder in people where there's no concerning features like hematuria or concerns about incomplete bladder emptying. Again, you would do a post-void residual if someone had symptoms of incomplete emptying or you're very suspicious of this, but otherwise you can move forward in treating them. And it's also a great diagnosis to follow people up with when you've seen that person, done their initial diagnosis, and you want to follow up with them in 6 weeks to see how your treatment decision has worked out. Telehealth is great because most times you're not actually going to be doing any physical exam or intervention. You're going to be assessing their symptoms.
That's great. Really nice summary of it. So maybe I'll summarize and you tell me if I've interpreted it correctly. So if you're seeing a patient with the symptom of overactive bladder, some of the core elements is urinalysis at some juncture to, rule out infection, inflammation, hematuria, physical examination with pelvic examination. But for the straightforward patient, you don't need to do a cysto, you don't need to do urodynamics, and unless their history suggests it, you don't necessarily need to do a PVR. Is that an accurate summary?
Yeah, that's correct. And again, next time you see them in the office, doing a pelvic exam to rule out severe pelvic organ prolapse or an extremely large prostate. Those are all things that you'll get to at some point in time. But again, you can move forward with treating these people at initial visit.
So let's assume we've gone through this initial evaluation and you really do appear to have a diagnosis of idiopathic overactive bladder. Talk to us about, initial management. What's new? Is this a stepwise progression from A to B to C to D, or have we start to rethink some of this and not necessarily move A to B, B to C, C to D, so on and so forth? Talk to us about the initial management.
The group decided unanimously that the concept of step therapy is not patient-centric. The idea that a patient has to go through all the steps to get to the end of the treatment paradigm is not serving our patients well. So we've eliminated the concept of step therapy. All of our therapies have been grouped according to invasiveness because that makes sense. And there's no evidence either that someone does better with therapy C if they failed therapy B. So there's no evidence that, for example, with a botulinum toxin injection, you're going to do better if you failed medicines. That's never been proven. So we have, recategorized things according to invasiveness. And the invasiveness scale is, non-invasive, which is pretty obvious to people. That's things like managing comorbidities, managing your constipation, your diabetes, your weight, your fluid intake, things like timed voiding, things like bladder training, physical therapy. We considered anything non-invasive where there was no penetration of your skin and nothing taken by mouth, basically. Quitting smoking, things like that. Pharmacotherapy is obvious. That's medical therapy, standard medical therapy for OAB. Minimally invasive, we considered therapies that require an intervention, typically from a healthcare provider. And then there's invasive therapies, which are major surgical operations. So that's how we've classified things. And again, we put a big focus initially on managing comorbid conditions. Smoking, genitourinary syndrome of menopause, constipation, although they don't cause overactive bladders per se, they do aggravate it significantly, and treating these problems will have a big impact for patients. So that's one new aspect of the guideline. And again, at this stage, you need to educate patients and engage in shared decision making. Provide them with information about the different treatments that are available. And you have to take into account what their values are, their preferences and treatment goals. There are people who already have polypharmacy as part of their life and don't want more medical therapy. And you have to take that into account. So again, there is a very robust section and robust data on time voiding, urge suppression that we discussed in the guideline, because these are integral skills that everyone needs to learn. So it makes sense to do the easy, non-invasive, non-pharmacologic things first, and to educate people on these things. And again, you should offer the non-invasive bladder training, behavioral therapies, non-invasive therapies to patients so that they're aware that they exist, because there's also this concept of layering treatments. It certainly makes sense to manage your fluid intake and do urge suppression on top of whatever therapies you're doing. So there's no mandated layering of therapy, but it certainly makes sense. Again, you have to give people lots of options and lots of education.
That's a really nice framework of how you describe the thought process of how to potentially treat patients with OAB. Let's talk a little bit about pharmacotherapy, particularly oral agents, and I would say as someone like myself who doesn't do this a lot, it's sometimes a dizzying array of medications out there and classes of medications. And I would be honest and tell you that many times I'll rely on my residents to educate me on maybe the different classes and the different families. But what should we understand about oral pharmacotherapy? Obviously, this is a patient demographic in many cases, not always, but many cases is an older patient demographic, whether that's men or women. How does that play into the decision making? Talk to us about that.
There are two major classes of pharmacotherapy that are well studied, grade A evidence, and years of evidence on antimuscarinic medication. We're all familiar with those. There's long acting and short acting. And then there are the newer beta 3 agonists, of which there are two. And both are considered standard. Guideline statement says you should offer one or the other to improve their symptoms. However, you do need to counsel patients about the side effect profile of each of these medications, since they are vastly different. They are completely different receptors with different side effect profiles. Our antimuscarinics clearly have the risk of dry eyes, dry mouth, and constipation, and sometimes some dyspepsia. And there is the theoretical or potential risk of development of dementia, which is very well known in the lay press. Patients are aware of this, and you need to bring this up because they all know that this exists. And I think it's a real concern for patients, and I think it should be. So you do need to bring this up with your patients. And certainly if you have someone at risk of cognitive decline or who already is experiencing some cognitive decline, you should think twice about prescribing these medical therapies. And the beta-3 agonists also have their side effect profile, although it is much smaller. There is the risk of hypertension and the risk of interaction with some of the cardiac medications, but these medications have a much narrower side effect profile and are tend to be better tolerated. But again, there are patients who will respond better to one or the other. And that is basically basic pharmacology 101. You can treat a condition by targeting these receptors or those receptors. And it certainly makes clinical sense if someone tries a beta-3 agonist and does not get symptom relief. Trying an antimuscarinic is an excellent other choice, provided that they are not going to be too bothered by side effects. Again, all medications have risk. And we did do away with the concept of refractory overactive bladder. We thought that was kind of unnecessary, and someone doesn't need to be refractory to move on to other therapies. So we don't mention the word refractory, and we try to avoid using it. It's basically someone has tried medications.
Got it. So you described earlier that there's been this thrust to go away from this step therapy. And I think that there are certainly, as you alluded to, some patients who either have maybe an aversion to oral pharmacotherapy or maybe are just on a myriad of other medications and they don't want to add yet another one to their mix. And so talk to us a little bit about what's new in the realm of minimally invasive therapies. And I guess, minimally invasive was always appealing because you would, I guess, intuitively think maybe the burden or the procedure or is not as quite as high as, what we would think about as major surgery or something that would result in long convalescence. So talk about new minimally invasive therapies for idiopathic OAB.
Sure. So to touch on, the perhaps avoiding pharmacotherapy option, there are people who are completely averse to long-term oral therapy. The concept of here is this medication, you're going to take it for the rest of your life. How do you feel about that? Mm-hmm. is a little bit disconcerting. And if you look at other guidelines, they offer more invasive therapy as an alternative to daily medication for the rest of your life. So I think we can all wrap our heads around how that's a shared decision-making option. We are not curing overactive bladder. We are managing overactive bladder. So giving people the option of moving on to more definitive therapy. And again, those people with comorbidities, heart disease, or who have, for example, Sjogren's disease, where antimuscarinic medications are going to be so aversive to them, jumping straight to the minimally invasive therapies may be their best option. So there is sacral neuromodulation that has been standard of care for overactive bladder for a very long time, an implantable electrical stimulation device. And there are updates. All available products in the US are currently MRI compatible. There are rechargeable versions, and then there are long-lasting implantable batteries that last upwards of a decade. So that space hasn't changed that much. Mm-hmm. Percutaneous tibial nerve stimulation has been around since the last guideline. Again, is cumbersome, but very effective for patients and is an option with almost no restrictions, very minimal side effects. It's just the time component. But we also have botulinum toxin injection of the bladder, which again was featured in the last guideline, still considered a mainstay of treatment. But what we've included in this version of the guideline are the implantable tibial nerve stimulation devices. Again, small devices implanted at the level of the tibial nerve, providing electrical stimulation, which are currently FDA approved. But this space is growing at light speed. There are multiple devices that have different ways of stimulating the nerve and different implant techniques that are seeking FDA approval. So I think we're going to see a rapid change in that area, and is probably going to be very appealing to patients to have a very small incision on your ankle. And these are often office-based treatments. So I think that space is expanding rapidly. And There are also transcutaneous options that are being actively explored. Again, people can place sensors on the skin and provide the stimulation to that area. Again, that is a rapidly evolving space where I think we're going to see a lot more in this area. There are already products on the market that will stimulate the perineum, will stimulate the ankle. And I think these are, we're going to see a lot in this area. But again, a patient doesn't need to fail oral agents to move on to these therapies. This is shared decision making. We're waiting for insurance providers to catch up with this recommendation. I think reality is that many insurers do require patients to trial less invasive treatments first. But again, we're hoping this guideline will provide space for clinicians and their patients to make the best decision for them and not to force people to go through steps that may not serve them.
So maybe just to follow up on this concept of minimally invasive therapies, and you talked about several of them: sacral neuromodulation, botulinum toxin, tibial nerve stimulation. How do you help a patient decide between them? What are some of the factors that would play a role, at least in the patient counseling aspect, to help maybe for those that are interested in this go with one direction versus another?
Currently, there are 0 head-to-head comparisons of those therapies that I just outlined to you in their standard format. Botulinum toxin, 100 units, sacral neuromodulation, PTNS, and implantables. 0. There is nothing that compares them head-to-head. There are studies that have provided comparisons, but not to the current therapy. We know that individually they do achieve effectiveness, and it would almost seem the same, although botulinum toxin likely has an increased dry rate compared to the other therapies. However, there is nothing in the literature to tell me one is better than the other. So now this becomes what's called a preference-centered decision, meaning when the data is equal, there are different things about these therapies that you share with the patient, and you see what matters, what their preference is. If someone is completely averse to having a scope put in their bladder every 6 months and have an injection of their bladder wall, typically in the office, if they think that's the worst thing that could ever happen to them, maybe we should talk about other therapies. If someone lives a 5-hour driving distance from you, PTNS is not going to be a very good option for them. There are people that have very strong feelings about implantable devices or don't want to go to the operating room. So there are nuances to each of these treatments. There are also comorbidities that factor into this in those patients who have dual incontinence with fecal incontinence. Sacral neuromodulation is FDA approved for fecal incontinence. So why not help the patient move towards that direction? The other is non-obstructive urinary retention. If someone is not emptying their bladder well and also having urgency incontinence, botulinum toxin is going to make one of those problems worse, whereas sacral neuromodulation may treat both problems. So in the absence of those comorbidities, I really share with patients what their different options are. And most people actually have a very strong opinion on what would work better for themselves. They know what's more agreeable to them or less agreeable to them. And you can explore that further. So it's actually, once you explain it well to people, they tend to get it and make a choice based on their own life and preferences. Having a decision aid is fantastic. At our site, we have a decision aid that outlines all of the treatments in one big handout, pros, cons, how they're different. And I find that extremely helpful. I actually provide that at my initial visit with a patient saying, in the future, if this doesn't work, we may move on to these to educate them ahead of time. So it's complicated. It's unlike other conditions where you don't have a lot of options to offer people. We have a lot of options and not a lot of data on what's best.
Sure. So we started off early in the program. We talked about for the straightforward patient with idiopathic OAB, we don't do a cystoscopy, we don't do urodynamics, but I'm sure there are instances where this does play a role potentially in the treatment algorithm, in the diagnostic algorithm. Talk to us about that. When should or when does cystoscopy, when does urodynamics play a role in the evaluation of these patients?
For that patient with microhematuria, cystoscopy is mandatory. When someone has microhematuria, I ignore the overactive bladder guideline, go straight to the hematuria guideline and finish that workup before entertaining moving forward with overactive bladder. As we all know, carcinoma in situ tends to have urgency as one of its presenting symptoms, so that's not something you want to ignore. Also, there are patients that have unique features of their history or symptom presentation that make you suspicious. Someone who's had an exorbitant number of urinary tract infections, you would probably want to look inside their bladder to rule out pathology that may be driving this. Someone who has symptoms suggestive of a stricture, someone who's had a lot of urethral dilations or procedures in the past. Again, someone who meets me and has had 2 slings and is now having urgency incontinence. I am absolutely going to do urodynamics on this patient because I have alternative diagnoses in mind. If I'm suspicious for obstruction, if I'm suspicious for poor compliance or other conditions, I certainly move towards urodynamics. But your straightforward patient who's never had pelvic surgery or radiation, who presents with a gradual onset of just worsening urgency over the years, and now it's urgency incontinence, their urine's clear, they have a normal post-void residual, that person doesn't need an extensive workup to get moving along the treatment pathway. However, when you move along the treatments that are available and you've done some really good treatments, for example, you do a botulinum toxin injection or sacral neuromodulation and they get no efficacy whatsoever. That's confusing. That doesn't make any sense. Those therapies are very effective. They should have some efficacy. And that's a hint that you need to maybe go back to the initial diagnosis. And again, I think we weren't prescriptive about this in the guideline because we know that providers have common sense and they know when things are straightforward, when things are not. So we say you don't have to do cystoscopy and urodynamics, but you can if that's part of your question answering to get the right diagnosis. And we know that providers will use their best judgment and do a good history and physical to start with and know where to go from there.
So maybe in the last 5 to 7 minutes, I'll do a little bit of maybe quick fire with you and ask you a few sort of questions and your thoughts from what the guideline panel compiled. The first is we've talked about non-invasive therapies. We've talked about oral pharmacologic therapy. We've talked about minimally invasive therapy. Where does more involved surgery, diversion, augmentation, or maybe permanent forms of or not permanent, but other types of urinary diversion, catheters of any sort, where does that fit into all this? And talk a little bit about that.
So we would lump those in invasive therapies. And in the guideline, we do address them. And these are not therapies that you jump to using shared decision-making. This is a last resort. And as urologists, we all know how to do these invasive therapies, but it really has to be very, very strong patient selection. In my practice, people who have failed our minimally invasive therapies, they've failed sacral neuromodulation, they've failed botulinum toxin injection and medications. And I have urodynamic evidence that they clearly have refractory overactive bladder while their therapies are ongoing. So say 4 weeks following a botulinum toxin high dose injection, someone is still having DO and incontinence, then those are the people where the idea of an augmentation cystoplasty comes into play, knowing that that patient has a greater than 50% risk of needing self-catheterization lifetime. And there's no way to go back on that plan. When someone gets an augmentation cystoplasty, they are committing perhaps to catheterizing for the rest of their life. And then there's the urinary diversion for that patient who may have a bladder that is so non-functional that an augmentation cystoplasty might not be effective, and they may have stress incontinence as well. And that would be an extremely rare extremely rare event to do a urinary diversion. Probably more common for the patient with multiple comorbidities and who has failed multiple therapies would be to proceed with a catheter drainage. Again, your frail elderly patient who would not be a surgical candidate. Again, to remind everyone, please don't leave these people with Foley catheters. I often do a trial of Foley catheter, 30 days, Foley catheter. Let's see how you do. Maybe their skin heals. They may have terrible skin excoriation and are at risk of ulcers. And they tolerate the drainage bag. They tolerate the concept of catheterization. And then I rapidly get them converted to a suprapubic tube, which avoids urethral erosion. So urethral erosion is a real thing, and that will render them completely incontinent, probably irreversibly. But again, with those patients where you've run out of options and they're just not able or willing to have major reconstructive surgery, that can be appropriate, but that's the exception rather than the rule. So we save that. But again, we all have those patients who need to be dry. People can get ulcers, skin excoriation. They can get extreme pain in their perineal area from their skin being so denuded that they need to do something.
So, I'm sure as you go through the guideline and you look through the literature, you have a unique insight, as does a panel, into gaps. Where are the gaps in the literature? Where are the gaps in knowledge? And I think one of the most intimidating things as maybe residents, fellows, and junior faculty, when you embark on looking at the future horizons, research opportunities, questions to ask, is where to start and what are the questions that may be of interest. So maybe give us a little insight on if you're going to toe the water and you want to do research in this space and you want to maybe ask questions, where can people start looking at and where could they have an impact?
In the pharmacotherapy realm, currently we are treating muscarinic receptors, actually specifically the M3 receptor, and we are targeting the beta-3 receptors. But there are 5 muscarinic receptors. The bladder actually has a 2-to-1 ratio of M2 to M3 receptors. And currently, there are no therapies that target the M2 receptor. I think that is an unknown mystery. But there's also cannabinoid receptors in the bladder, purinergic receptors in the bladder. I think there's a lot of untapped potential in terms of what pharmacotherapies could target the bladder. Again, pharmacotherapy is appealing to patients. Again, this is not a life-threatening condition, but it's a severely quality of life-threatening condition. And if we could develop medical therapy that works really well, I think patients would be very grateful. And we also don't even know how long to trial therapy before moving on to another therapy. This was an important question during guideline development. We asked, how long do you have to wait before transitioning to another medication? And most studies use 12 weeks as their time point. Now, that's ridiculous. You're not going to make someone take a medication for 3 months before switching therapy. So it would be great if someone could give us a little bit better guidance on when to cut our losses and move on to other therapy, because patients get lost in this drug therapy, swirling the drain, trying 4, 5, 6 medications, changing meds every month, and then they get really irritated and abandon care. Very few patients progress on to minimally invasive therapy, probably because they get frustrated. Someone's just throwing more and more and more medications at them when they actually want to be dry. So that's what they want. They don't want to try 10 different medications over 3 years. They would like some efficacy. Like this is not rocket science. We all understand that. Again, patients want to know how to prevent incontinence. The PLUS Network Rise for Health study is ongoing, assessing how to prevent bladder symptoms throughout the lifetime. It's focusing on women, but I'm really excited to hear what they have to say about how we can provide public health information on how to keep your bladder from developing bladder conditions. And minimally invasive therapies, I've already touched on this, we're sorely at a loss for studies that compare our minimally invasive therapies to head-to-head. Patients want to know. Patients want to be dry. Patients want to know what the side effects are. So if someone could please compare them head-to-head and give us an answer, I would be eternally grateful. And again, I think those studies certainly need to include patient preference and regret, because people will have therapy and regret that. And I think that's an important aspect of getting the qualitative impression. And especially, please include men in your studies. Please, please, please. The data on botulinum toxin in men is handfuls. There is pretty good data on sacral neuromodulation, but the data in men on the studies with botulinum toxin, they make up 7% of the population. So that's just minimal numbers. And I feel like we're more guessing than providing data to men who are deciding to undergo these therapies. So I think there's a sore need of treating men with overactive bladder and providing them good data. And again, please, if you're doing studies on overactive bladder, include your racial and ethnic minorities, your frail and older adults. All of these people get overactive bladder, so please don't select a young female population to study. Study all people that get overactive bladder, and that will help us provide better information and treatment for our patients.
Well, and that was really super. It really covered a lot of ground on that guideline, clearly very thoughtfully created. I really want to thank you for your time today, obviously the guidelines panel and the entire team for what sounds like an enormous amount of effort to craft this really well thought out guideline. So big thank you.
Great. Thank you, Jay.
To our listeners, thank you for joining us today. I would highlight once again that the full guideline is listed on the AUA website and will be also tagged to this podcast. So you can feel free to, of course, use that link and read about any of the details that Dr. Cameron has walked us through today in greater detail. And I look forward to seeing you soon. And again, a big thank you on behalf of the AUA for your time today.
Great. Thank you.